Hi, everyone. I'm Donna Hartland, the Executive Director of the GBS CIDP Foundation of Canada. We're excited to have this edition of the Ask the Expert with our Medical Advisory Board, Dr. Hans Katzberg, which is part of the University Health Network, Toronto Western Hospital, and the Posserman Neuromuscular Diseases Clinic. And he's here to help us out with issues in vaccinations, in particular, some information with our conditions. And we thank you very much, Dr. Katzberg, for taking this time out to help our patients.
Thank you, Donna, and thank you for the GBS CIDP Foundation for the invitation. As Donna mentioned, we'll be talking about vaccine-related issues in immune neuropathies, in particular, how does it apply to CIDP, GBS, and MMN. This was a talk that I gave during one of the national meetings last year. It was important back then, and it certainly is ever more important now as we are tackling with COVID on many levels. So we're happy to have this talk once again. Some of the objectives will be to talk a little bit about the background related to vaccinations, as it will put the rest of the discussion in context. A little bit about the vaccines and the risk of either developing or worsening GBS, CIDP, MMN. This is top of mind for many patients. Also, someone in particular with CIDP is receiving chronic immunotherapy, how are vaccines dealt with then? And then finally, we'll end up with some other practical considerations and questions. And there were some questions that came in either already in anticipation of this talk. So I've made sure I tried to address as many questions as possible through the talk. And as always, happy to receive any queries after the talk as well through the foundation. Here are my disclosures, including the commercial disclosures. There's nothing relevant for this talk, but I should also highlight that all these concepts are general concepts, and every patient is different. So we can give general principles, recommendations. However, it's quite important to consult your own physician for specific advice about your own medical condition. So a little bit about background and history. Inoculation is a concept by which live pathogens, so either bacteria or viruses, are used to develop immunity in a host. This is mentioned as early as perhaps the 10th century. And then in the 18th century, smallpox was decided on one of the very virulent pathogens that was aimed to be tackled with some of these concepts. So this was smallpox, which was responsible for up to 20% of deaths in some countries. And a big breakthrough in the 18th century was that cowpox is a pathogen that was found to be very similar to smallpox, but did not cause disease in humans, but could be used to develop protection, immune protection against actual smallpox. And these concepts were then furthered by Louis Pasteur in France in the 1800s, and that's when vaccines really took off as we know them today. What about the mechanism and biology? How do vaccines work? So as I mentioned, the concept is to work with the body's natural defenses to develop immunity to a disease. So either a weakened or killed form of the disease, virus or bacteria, is injected in the body. The body then creates antibodies to fight against these germs. And once someone is actually exposed to this virus or bacteria, then the antibodies can return because they are present in order to fight the virus or bacteria. And the other concept on the right here is that of herd immunity. You may have heard a lot about that in the news in recent months and similar graphics. And here's how it works. Healthy people in the light blue in the top panel here. And once someone gets sick, highlighted in the red, depending on how virulent it is, how infectious this agent is, it could spread rapidly or aggressively in the community, as you can see in red here. If a few people are vaccinated, immunized against the agent, but does not reach a certain threshold, then that virus or bacteria can still spread, as can be seen here on the red. People here on the right. However, if enough people are vaccinated and it reaches a certain threshold known as herd immunity, then that will prevent the spread of the bacteria or virus. So enough people have to be vaccinated. That's why you see and hear so much about this, because it's not enough for just a few people to be vaccinated in order to protect the community as a whole from these agents. So what are the benefits of vaccination? Well, it has the ability to reduce the disease, so actually catching it. If someone catches it, perhaps it can reduce the disability, how strongly someone is affected by it, because they do have some immunity against it. And on the serious end, it can prevent death in some viruses and bacteria where the mortality rate is very high. And the goal ultimately is eradication, to prevent these conditions or diseases from spreading or becoming at all prevalent in the population. So vaccines naturally can be administered to children and adults. So it's not just for children, and it's not just for adults either. And they can offer lifelong protection in some cases, and in some cases there's boosters that are needed to optimize the vaccines if the immunity weakens over time. So every vaccine really is different. And that's the reason I think now during the pandemic, you're hearing a lot of work and details being examined because in fact, once each vaccine is developed, they act differently and independently, perhaps even from different makers of the vaccine. So paying close attention to those details are important and are still yet to be available for COVID-19 as these vaccines are being developed. What are some challenges? The vaccines may not be available everywhere in the world, particularly in low-income countries or places where it's difficult to access the whole population due to geography, for example. But many times they can be administered relatively easily. So there's different ways to administer vaccines. Some are oral, by mouth, some are injections, intramuscular. But the goal is always to have an overall good safety profile because the fact is that the vaccines themselves should have low or no virulence or sort of effects on patients. So that's what everyone's paying attention always, first and foremost, when vaccines are being developed. So here's an example of smallpox. I made that example early, one of the first diseases that was tackled. And you can see here the global number of reported smallpox cases as early as the 1920s, very active into the 30s, 40s. And as vaccine programs were being instituted, this really led to a decline in the number of cases, leading to essentially eradication of this in the 1980s. So this is the benefits and the goals of all vaccination is to eliminate some of these very, very serious diseases worldwide. What about concerns? You've heard a lot about concerns in the media from people. So why is there this concern if the goal of vaccines is to protect health? Well, some patients have difficulty tolerating the vaccines. So it is true that there can be some rare allergies to the vaccine, and there can be some rare instances where people react through an immune mechanism to these vaccines in different ways, or with someone that has a weakened immune system, and that can cause disease or perhaps even other unintended effects. So people are concerned about this. Severe immune reactions themselves also have been reported. However, as I'll highlight shortly, this is not the rule, this is the exceptions, and although they can occur, these are rare events. And the goal is always to have these to be at the minimum or non-existent, if at all possible, in order to reap the very positive effects that can come from vaccines, which I'll go over as well. Some other objections, people have some personal beliefs against vaccination, perhaps even that they do not work. Because if the goal is to not have any disease, if it's not around, people often question that, how do we know that it's actually doing anything, especially when disease rates are very low. When they're top of mind, like in COVID right now, I think we will do anything to kind of bring those numbers down. But when it's really at low levels, sometimes people question these things. The other concerns, perhaps, are government interference and corporate influence and profits from vaccines. So these are all valid questions that people have. And as mentioned, I'll try to address some of these medical questions throughout the talk. So before we go into some of those specifics, just how to categorize vaccines. It depends on the formulation of the agent itself. So some of the vaccines are made from live vaccine products, so live viruses, which are then what's called attenuated, meaning they're changed so that they don't have the virulent or disease-causing aspects. So some examples of these are tuberculosis, oral polio vaccines, measles, or yellow fever. But the majority of vaccines are actually not made with actual viruses that are attenuated and live, but actually completely inactivated, as in certain vaccines, whole pertussis and inactivated polio, or are made from parts of the virus or bacteria, protein subunits, polysaccharides, which are sugars, a conjugate, which means some combination of products, and other similar subunits, and they're listed on the right here. So the majority of the vaccines are not what's called live attenuated vaccines, but they're made with some component of the agent. So what about vaccines and GBS? So one concern that you might hear, and I'm going to mention it first, is that perhaps vaccines can cause GBS. This is something that was observed potentially back in the 1970s. And let me go into that in detail because there's a lot of lack of clarity about these kind of topics. And I think this is one of the main reasons that some of these issues have been raised. And that's that in the 1970s, there was a rate of GBS occurring, which was reported initially as about 1 to 2 in 100,000 in relation to the flu vaccine. So this led to some concerns. There was also some concerns, never substantiated, that perhaps neurological vaccines could have a higher chance of causing neurological problems. But really this was not so. And the link between some vaccines and GBS actually were really very low or non-existent at all. So the flu vaccine, I think, was paid a lot of attention to. And this was a certain type of flu vaccine to a US swine flu influenza program. As I mentioned, about 1 in 100,000. That was noticed in some army recruits and trainees. And this then led to a lot of very close epidemiological attention paid to this to really determine, is this a real link? This flu vaccine, does it really cause GBS at this rate of 1 in 100,000? Now you can see that 1 in 100,000 is not a high rate to begin with, but still, when you're dealing with a lot of vaccinations, this is important. So it was queried more judiciously, and a lot of attention paid to it over the years. And subsequently, with much more investigation done into the 70s, 80s, 90s, and even into the 2000s, it was determined that this estimation of the relationship between certain flu vaccines and GBS was probably an overestimation. Pandemics or epidemics never really had an outbreak subsequent to that, so it's difficult to challenge some of these, but there was a lot of great epidemiological work. The point of this slide is not for you to read all these different studies, but as you can see, there was many studies performed from the 70s I mentioned into even the 2000s, where it showed that the risk of GBS from the flu vaccine was probably much lower than was previously identified. So perhaps less than 1 in a million. And Health Canada has actually put out recommendations on this. One of the main questions being who should not receive the vaccine. But prior to that, this is from the Health Canada website, who should receive the vaccine. So everyone greater than 6 months of age who does not have a contraindication to the vaccine should be considered, especially the following groups that are at risk. So people at high risk of developing the flu-related complications or hospitalization, people capable of transmitting influenza to those at high risk, those in essential community service, and direct contact with poultry infected with avian influenza during culling. So certain circumstances. So as you can see here, people that are high risk of developing influenza-related complications, some of these may be patients that are actually immunocompromised or have weakened immune systems, because getting the flu in those patients can be very serious. So this is why the recommendation is out there for the flu vaccine in patients with immune neuropathies. And we'll go over the details in a second. Who should not receive the vaccine? So there's actually very few situations where someone should not receive the flu vaccine. One of them is if you have an allergy to any of the components. Some of the components are made with egg products, for example, so, and some other components. So if there's an allergy to any of the components, this should be avoided. And here's the point that I think is of most interest to patients who have had GBS in the past. If someone has had GBS that was thought to be related to the influenza vaccination, then people in that category should avoid the influenza vaccination. But that is a very limited number of patients out there. And the reason is the relationship between GBS and the flu vaccine, I think, has to be pretty solid in order to fit into that category. Meaning not someone who has had the flu vaccine at some point in the past, but really in very close proximity to the development of GBS without any other reasons for it. And the time frame for that is at the most 6 weeks after the administration of a vaccine. In those few people that have had that scenario, those are really the only people that should avoid the flu vaccine. And as you can see up at the top, everyone else, I think, should be considered for the influenza vaccination. Why the timing? Why 6 weeks? Again, we really want to have a very strong relationship that GBS has occurred after the flu vaccine versus many other exposures that can occur. In fact, most people that will develop this, this occurs within 2 weeks, and at the most and at the extreme up to 6 weeks. And if it occurs after this time frame, it's unlikely to be related to the vaccination. So what does this mean for everyone else? Really, most everyone else with GBS can receive the flu vaccine if these conditions are not met. So what about the benefits of vaccination? So it's strongly, in addition to Health Canada, also recommended by the World Health Organization for high-risk groups, for the Centers for Disease Control and Prevention, CDC, also for those age 6 months or older and don't have the contraindications. And in healthy adults, it is modestly effective in decreasing the amount of influenza-like symptoms. So it's not a perfect vaccine, but it does work. And in healthy children over the age of 2, then this reduces the chances of getting influenza by about 2/3. And a major review of vaccination in children found that immunization seemed to lower the risk of getting, for example, influenza from 18% to 4%, and some other vaccines from 30 to 11%. So these vaccines do work and prevent some of the very severe complications that can happen. This can happen in anyone, but in people with weakened immune systems, even more so. So some of the common symptoms you know about on the panel on the left here: fever, cough, sore throat, muscle aches, fatigue, vomiting. But another important thing to realize, and has been, again, attention in the media often lately, is that there can be very severe complications from the flu, life-threatening perhaps, pneumonia, inflammation, reactions that can occur, and yes, including GBS or worsening of other immune conditions, just because the immune response you get with the flu is very, very significant and can result in these. So trying to prevent these, I think, is important. So what else have we learned in very recently? Some of those studies that I mentioned before, as mentioned, some of these are really just related to the flu vaccine and back from the 1970s and have been queried in different scenarios over the decades. But there's been an initiative worldwide, many countries, Canada was involved, called the International GBS Outcome Study. Many centers in Canada participated in this, and this is trying to gather some up-to-date information, not just relying on certain groups that have done epidemiological studies, but really prospectively, meaning going forward, looking at many new cases of GBS to get an updated picture around the world of what triggers GBS, what is the natural history of patients with GBS that have or have not received treatment. And one of the point here that I'd just like to make is that most cases of GBS really occur with infections. So this is upper respiratory infections, gastroenteritis, and under other, out of many hundreds of patients, almost 1,000 and now 1,000 plus patients, 14 of those patients had other triggers for GBS, and amongst those, a few of them were vaccinations, but again, this is quite rare as an actual trigger for GBS. So the infections are by far the majority of triggers for GBS, occurring about 60% of the time. What about vaccinations and CIDP or MMN? There's really not much data on that, but there's one Italian study done recently, which also tried to get at antecedent events. These are what's happened prior to someone with CIDP perhaps getting worse or worsening. And again, a lot of these are flu-like illnesses, infections, either respiratory, GI. And in these cases, vaccinations were thought to worsen CIDP about 1% of the time. So just like any other immune trigger, including infections, which are more common, CIDP can theoretically worsen. However, the numbers are very low. So this actual impression from this study was that the study seemed to suggest that antecedent events are unlikely to play a major role in the risk of CIDP, and the keyword there being major role. So all these things can occur. So people with CIDP can get infections, and there can be worsenings, the fluctuations up and down. But generally, the thought is that vaccinations are safe in patients with CIDP, and that could be safely administered. MMN is even more rare of a condition, so there is even more limited information on whether vaccines or other infections can worsen MMN, cause flare-ups. But again, the same principles apply. It's an immune condition, so patients can fluctuate and have different triggers that can make their condition better or worse over time. What about vaccinations while you're immunosuppressed? I was talking about these conditions in general terms, but and it's important to note that patients with GBS are going forward, their immune system really is not compromised, because all patients with GBS really should not be on chronic immunotherapy. If you've had an immune event in the past with GBS itself, but people with GBS are not, for the most part, on regular immunotherapy. So really, we're talking about people with CIDP who can require ongoing immunotherapy, which includes immunosuppression or immunomodulation, which could include IVIG. People with with MMN, for example, are not as often on the traditional immunosuppressants, such as steroids or other similar things, but are on IVIG often. So how do you deal with vaccines when you are taking one of these agents, perhaps, that leads to either immunosuppression or modulation of the immune system? So the general principle is that live vaccinations should be avoided in someone who is taking immunosuppressants going forward on an ongoing basis. So which are these live vaccinations? I mentioned them previously. Really, some of these vaccines are actually no longer used or even made. So the concern comes much lower. So an older version of the flu vaccine, which was given intranasally, fits this category. The older shingle vaccine, which as of November will no longer be made or available in the United States, and similarly in Canada, because there's a newer shingles vaccine, TB, oral polio, measles, and yellow fever. So these are the ones I mentioned earlier. Killed or attenuated vaccines are safe to administer, even while on some sort of immunosuppression or immunomodulation. And as I mentioned, there is a few exceptions when someone is taking IVIG. I'll mention that in a second. And I also added the point that it is not recommended, in fact, to avoid or miss necessary vaccinations while you're receiving immunotherapy, or if you have one of these conditions, if there is no major concerns or contraindications. And the reason is there have been reports, some of them are not related to patient choice. Sometimes these things are difficult to access. So throughout the health systems, patients, patient groups, hospitals, clinics, I think there's a big push to try to recommend to patients to avoid missing necessary vaccinations because of a concern that there could be major outbreaks of some of these other conditions if these are avoided. And as I mentioned, without herd immunity, this can spread also very aggressively. And this is things other than coronavirus that can double how serious people are affected in the community. What about special circumstances? What about travel? So when you travel to certain countries in the world, vaccinations are required. So again, as long as they're not live vaccinations, it should not be an issue. So a lot of this is dependent on which country one is traveling to. So there, it's quite important to get recommendations from healthcare professionals, your family doctor, travel clinics, But the main concept is that as long as they're not live vaccines and you are not receiving ongoing immunosuppression, then things should be okay for you to take. What about vaccines during an attack or a flare-up of CIDP or GBS? Here is where there's not much good evidence, but in general, it is recommended to avoid vaccinations during these attacks because they are immunogenic. They can alter the immune system. So during an actual attack, one would want to avoid that. So the question is, when would it then be safe to restart? And this changes depending on the person, their actual attack, and their actual clinical phenotype or their actual clinical experience. So I think this is important to talk to your physician about to see once the flare-up or the attack has occurred, usually probably in the order of weeks to months, then when is it safe to restart the vaccinations? What about new vaccines? And here, again, avoiding too much coronavirus vaccines, top of mind for everyone, myself and other professionals. But really, we want to be very careful about applying some of these principles to each individual vaccine because there's still a lot of unanswered questions about this. But the concept is that with the introduction of newer vaccines, there's usually less safety data. So it's important to keep that in mind. And every vaccine is different. How long it confers immunity? Does it need a booster? So what are the safety parameters? This is something that's currently being investigated, and I think will be very important to keep very close track on as it becomes available and see how it applies to each patient group. So again, consult your physician with up to the date, and certainly our patient groups will have comments and position statements on this very soon after they're available. So keep the foundation and other similar groups keep track of some of their postings and materials in order to have this information. Some additional questions and our suggestions. So one question that came in prior to the talk, which I think is quite important, is it possible to receive a vaccine while on IVIG? And again, here, inactivated or live oral vaccines, which are the most, should have no effect from IVIG. There is an exception, and again, this is some of these live attenuated vaccines. Measles vaccine, measles and rubella vaccine, MMR, is an exception. This is not recommended to be used in those patients receiving IVIG or sub-Q. And if one is able to go off of these medicines, it is recommended to wait about a year after the last administration, particularly at the doses that are used for immune neuromuscular conditions like CIDP. The other exception being the monovalent or the older shingle vaccine. But again, that is not as important or relevant now because this is being phased out or discontinued. So I mentioned that during an active phase or a flare-up of CIDP or GBS, one should avoid vaccinations. What are the other scenarios where you might want to avoid vaccinations and discuss further with your physician? Well, one is during an actual infection. So if you're actually in the process of experiencing the flu or another infection, it is recommended to avoid vaccines during this period of time. And it's also recommended to avoid multiple vaccinations together. It's best to spread these out. The exception to that, I think, is travel, where a number of vaccines have to be given together. But even in that scenario, I would recommend to talk to your physician or travel clinic and try to see what the possibility is to spread out these vaccines safely in anticipation of any trip. And the final point is that we do recognize that many patients know or recognize symptoms of a flare-up or development of GBS or CIDP. And we would encourage, if you develop any symptoms after receiving vaccination or after any sort of infection, if you start to feel these symptoms, to consult with your physician, head to a doctor to get things checked out and get an objective assessment on whether this is at all causing any sort of neurological problem or injury. And finally, we do work together as a medical community, especially those of us managing and helping patients with immune conditions. What are some other immune conditions? Within neurology, myasthenia gravis is another condition that is immune that deals with very similar issues with ongoing immunotherapy. Patients with multiple sclerosis, for example, again, also very similar in that it is an immune neurological condition. So all of these groups have strong presence with patient advocacy and have some vaccination-related concepts and recommendations. You know, if you have CIDP, GBS, or MMN, I would recommend to go to the national and international pages for your particular condition. But just to mention that we do work together, all of the medical community, to learn from each other and different experiences related to vaccines or other triggers for immune conditions. So to conclude, there may be a small risk of increased risk of GBS with the flu vaccine, particularly with the swine flu components over time. But as I mentioned, this is quite rare, probably in the order of 1 in a million. And this may be outweighed by the risk of actually getting GBS from the flu itself, which is probably much more common, or worsening of your immune condition from the flu itself. So trying to avoid the flu or other similar strong virulent conditions, I think, is key. If someone has had the unlucky scenario where they've developed GBS, as I mentioned, usually within 6 weeks of receiving a vaccine, particularly the flu vaccine, Health Canada has recommended in that particular scenario to avoid this particular vaccine, the flu vaccine. And in general, those with CIDP MMN who are actively treated with immunosuppression should avoid live vaccines, particularly some of the ones that I mentioned, TB, oral polio, measles, and yellow fever. Really, the intranasal flu and older shingles vaccines are no longer relevant, but are on that list as well. Patients should avoid vaccination during active infections or attacks or flare-ups of immune neuropathies, grouping or batching of multiple vaccines. And if you're actually actively taking IVIG or subcutaneous IVIG or subcutaneous immunoglobulin, the MMR, the measles, mumps, rubella vaccines also should be avoided. And finally, as a general point, patients with immune neuropathies should seek medical advice if medical symptoms similar to a previously experienced neurological condition develop after vaccination within a short period of time. And I would also recommend and encourage everyone to confer with their physician and position statements from patient groups and organizations on advice relating vaccinations, particularly as new vaccines become available, including the coronavirus. So pay very close attention as this information becomes available. And with that, I'd like to thank again the CIDP GBS Foundation. More resources are available on the website, and always happy to continue to work with them to get all the right information to patients. So thank you very much, Donna and group, and look forward to continued interactions.
Well, Dr. Katzberg, that was very informative. I've even learned some new stuff here, which is fantastic. And we can't thank you enough for your time. And I'll thank you on behalf of the patients that are going to review this. It's an excellent resource for everyone to see. So again, thank you very much.
Thank you, Don. I think we're all learning together and we'll continue to do so. So thank you very much for the invitation.
Okay. Thank you very much. Please go to our website, which is listed on our page, on the page here, to register as a patient or a caregiver, and for any information that you would like on our services and programs. Thank you again, Dr. Katzberg, for providing this presentation to our patient group.